Okay,
right, you ready?
well, good morning everybody. We are going to do our castration demonstration and we will be starting in the prep room. We have Luca with us and Dr. Turita is going to be holding him for his catheter placement by Dr. Michio. On stage also we have Kwesi and Miss Peach and Jude. So as we have described before, we're going to start with clipping the area. Just be gentle. Some dogs don't like to be clipped, so if that can be fast. This dog has been pre-meted, but he's a puppy. He's excited and happy to be here with us. Just going to do a decent size rectangle, enough so that we can place a catheter in an aseptic manner. As any way to prepare your catheter, we're going to do chlorhexidine, alcohol, chlorhexidine, alcohol and sats 3 times at least. And we're going to make sure that you dry the area that has not been prepped, all the hair. Remember just if you don't know, our tape has problems. If we don't dry that, it will not stick to the leg. Okay, so we're going to open our catheter. Make sure that you separate the cap and put it back on, replace it. Lights are always a good thing to do. Some people like it, some people don't. Most of us do like to have some extra light.
Let's get him up.
Insert your catheter advanced. You can use one hand, but if not, you can use 2 hands. Your assistant is capping the end so that Dr. Michio can put the stopper at the end of the catheter. Don't worry, the blood is not going to flow in. It's a filter. It's going to stop it, and that's great. You'll have time later on to replace it with an injection port. Okay, first tape, sticky side down. We're going around the whole leg, and we're going to go with the tape halfway between the catheter and the skin. Nice and snug, not too tight so that you don't occlude the circulation, but nice and snug so that you know for sure that it's sticking to the leg. Remember, we dry the area so that happens. Second one, sticky side up. We're gonna make a little butterfly. And we're gonna go around the catheter once again. Make sure not to put it too close to the end of the hub so that we have some room for the lure later on. Last catheter, we look that there is a notch done. We're going to do the sticky side down. I can do it. And we're going to come around again, making sure that we again don't occlude the end of the hub, so that now when we replace the cap with an injection port, we're going to be able to lure lock it. Great. And now it's time to make sure that we're still in our beautifully placed catheter in the vein. So we're gonna flush it. There is absolutely no reason to aspirate right now because you just replace the catheter. So all you need to do is inject and have somebody feel to make sure that the catheter is patent. And once you do that, we're ready to go. So we have our induction agent, propofol. In this case, it might be alfaxolone later on for the space, but you'll see that in a different demo. You're gonna have some gauze available. Just remember, before you inject, there is a few things that you should do. You should definitely get a baseline, again, heart rate and respiratory rate. We know that you did it in the morning, but remember your patient has been pre-med, so things might be a little bit different now. Also, anesthetist should be able to measure the length. That is too short, yes. So measure, you have the size, but you didn't know the length when you decided on the size, so you need to make sure that your length is good enough. So you go from the tip of the mouth to the insert. No, we need a longer catheter, please. What size would you like?
8.5 or 9, please.
So we want an 8.5 or 9. The tubes are also graded, so if you have a 22 or a 24, you can ask your assistant surgeon or your surgeon or whoever is available for a 26. That will be a bit longer. Remember, you can always cut the tubes if need be.
A little longer.
This is a little longer. It's not huge. If you need it longer, the measurement is from the mouth to the thoracic inlet, right? That's what you use?
Yes. From the canines to the...
Canines, yeah, sorry, from the canines, exactly. If you need to cut a tube, it's easier to do it when the tube is not in the patient. So that is a good measurement. But it can also be done once the tube is inside the patient. Remember to always lubricate the choice or your choice of tube, ET tube, to have a brown gauze nearby available. And to have your laryngoscope ready and in good working order.
Just, I didn't check the cup on that. Sorry.
We have a couple of them.
If you have to choose a tube that you did not check the night before, make sure that you always check the cuff before you actually put it into your patient. They should all be working, but things happen, so it's always a good idea to check, make sure that it's remaining inflated, and we are good. Then deflate it to make sure that we can introduce into our patients safely.
Ready, Vincent?
Okay, I think we're ready. We have a base heart rate, respiratory rate. Our patient is okay. Our anesthetist is okay. So we're gonna induce. Somebody's gonna have a hand on the pulse. Make sure that you always do that. Dr. Turito is safely holding the patient. Remember, they can still wiggle and they can still bite if they want to. And we are going to definitely record the time. The time is now 9:16, and that will be recorded in your induction. In your anesthesia record. As you know, propofol is induced slowly to effect, and just take your time.
Also good. Okay.
As you're inducing, you're going to be able to assess the reflexes, assess how the jaw tone is feeling. And once you think the jaw tone is loose enough, then you are ready for intubation. Leave the induction agent where it is. You don't need to remove the syringe because there might be a possibility that you'll need to inject a little bit more propofol or inject induction agent, whatever it is. So leave it there, it's safe. Patients should not move. And then just make sure that the assistant surgeon is very important in this instance. See how she's holding the top of the mouth and she has the neck straight. By scruffing it gently, she's not causing any harm. Wait to induce here. Dr. Mitchell is able to hold everything in one hand, but you can have an assistant hold the tongue of your patient. And tube will go inside the trachea. As soon as you think that it's safe, you're gonna tie it and secure it with a brown gauze. Make sure you have an actual knot and that knot is tight into the ET tube. Make sure that the cuff is outside of the brown gauze and then tie it to the top of the nose. At this point, you can remove the induction agent now because the patient is going to be placed on lateral recumbency and attached to oxygen straight away. We're doing the leak check at this point, putting some pressure on, making sure that somebody was listening. They heard something coming out, so that means that the tube is still not well coapted to the trachea. Now Summer has gone into the cuff. Trying again. Don't go over 20 psi of pressure.
Yeah.
Nothing is heard. That means we are secured. The leak check has been completed. We're going to put him on a different recumbency. Make sure that when when the position is changed, you detach the tube from the oxygen supply. And now we have gone on to dorsal recumbency because we know that the patient is breathing and we are pretty happy. In some instances, remember to put, now that the leak check has been completed, we're going to put it on 2% of isoflurane. And now it's time to record. So the anesthetist student will start recording constants, heart rate, respiratory rate. We do not have pulse oximeter or anything like that in the prep room, but if there is an indication, we will bring it along.
Time of ISO.
Things to do now, attach the fluid line to the catheter, clip for the Doppler. Our scrub nurse is going to do that. It's going to clip for the Doppler so that we don't forget to do that later. We're going to do the eye lubrication, super important from the get-go, and tape the fluid line to the leg with a safety loop or just a straight line. It doesn't matter, but just make sure that there is an extra piece of tape holding that line so that we don't yank it and lose it quickly. And anesthesia will start recording and scrub nurse is going to start doing the clipping.
And your heart rate.
The vacuum. Oh, sorry.
On the other side so you can see the shading?
Yes. Yuri, can you come here? Yeah.